Good afternoon. My name is Nick Rebel, and I'm the Executive Director of the International College of Surgeons United States Section. On behalf of our executive producer, Dr. Robert Amajoy, who could not be with us today, it is my pleasure to welcome you to the latest installment of our 60-minute webinar series entitled Surgical Outreach and Capacity Building Around the Globe. It is my pleasure to now introduce our moderator for today's program, Dr. Katayun Madani. Dr. Madani is a Junior Fellow of ICS, as well as Decisions Special Liaison to the Executive Council of the U.S. Section. She is the MD Anderson Fellow in Global Surgery Policy and Advocacy at the Baker Institute for Public Policy and Department of Surgery at Baylor College of Medicine, where she also serves as a global surgery clinical instructor. And now, the moderator of today's webinar, Dr. Katayun Madani.
Thank you so much, Mr. Rubel. Hello, everyone. Good morning, good afternoon, and good evening, depending on where you are watching us from. It is a pleasure to be with you today and discuss global surgery and surgical outreach in the context of capacity building. The International College of Surgeons has a history of focusing on global surgery initiatives since its inception in 1938, and it has been part of the mission of the organization all along. The U.S. section has, of course, also been involved for the past decade, especially with variety of collaborators and partnering organizations, and many of our members are involved in global surgery activities around the world. Today, I'm joined by two esteemed speakers who have not only been part of the global surgery movement, but have made significant contributions to this field as it has evolved over the decades. So I would like to introduce our speakers. I am joined by Dr. Mark Perlmutter, who is the past president of the United States section of International College of Surgeons. He led the organization in 2002, and he is also the current president of the World Surgical Foundation. His involvement with the World Surgical Foundation has most recently taken him to Honduras for several mission trips over the past few years. Dr. Perlmutter is an orthopedic surgeon at Carolina Regional Orthopedics in Rocky Mount, North Carolina. Welcome, Dr. Perlmutter.
Good morning, good evening, good afternoon.
Next, we have Dr. Mark Schreim. Professor Schreim is the International Chief Medical Officer at the Mercy Ships and a lecturer in global health and social medicine at Harvard Medical School. He has had an illustrious career in global surgery, which includes serving as the O'Brien Chair of Global Surgery at the Royal College of Surgeons in Ireland. He's the founder and director of the Center for Global Surgery Evaluation at the Massachusetts Eye and Ear Infirmary, and also as the research director for the program in global surgery and social change at Harvard. He's the author of seminal papers in Global Burden of Surgical Diseases, the financial burden facing surgical patients, and a number of people who cannot access safe surgery worldwide. He served as co-author on the Lancet Commission on Global Surgery, and to date, he has worked and taught in Liberia, Sierra Leone, Guinea, Benin, Togo, Congo, Haiti, Saudi Arabia, Cameroon, and Madagascar. His research has been supported by the National Institute of Health, the Iris O'Brien Foundation, the Damien Runyon Cancer Foundation, and anonymous donations to the Center for Global Surgery Evaluation, as well as the GE Foundation's Safe Surgery 2020 project and the Stephen C. and Camilla Kelejian Foundation. His academic pursuits focus on patient decision-making and surgical delivery in low and middle-income countries, where he has empowerment in equity and global development. His work aims to determine optimal policies and platforms for surgical delivery that maximizes health benefits while simultaneously minimizing the risk of financial catastrophe faced by patients. In 2018, he was awarded the Arnold P. Gold Humanism in Medicine Award by the American Academy of Otolaryngology and Head and Neck Surgery. When not working, he is a photographer, public speaker, and rock climber, and he has competed on seasons 8, 9, and 11 of American Ninja Warrior. Welcome, Dr. Schreim.
Thank you, Kathy. It's good to be here.
Thank you. And Dr. Schreim today is joining us instead of Dr. Walt Johnson. Dr. Schreim, if you want to.
Yes. Thank you for reminding me. Yes, Dr. Johnson has taken a last-minute trip down to Madagascar for some of the work that we at Mercy Ships are doing down there. I'm deeply grateful for him doing that, and because it is 11 o'clock at night his time right now, I'm doing this talk for him.
Well, thank you for being with us today, and we wish Dr. Johnson the best on his travels. So we are going to start actually with Dr. Perlmutter. Dr. Perlmutter, go ahead, please.
My talk is going to be on outreach medical collaboration for capacity building. Kadiun and I developed this talk together, and she'll interject some thoughts as we progress. Next, please. The objectives of my talk will to be discussed what factors are necessary for capacity building. This entails success factors in medical outreach programs, how to explore mechanisms to build capacity through outreach medical collaborations, and complication preparedness in outreach medical collaborations. Next, please. Successful medical outreach programs require a very specific interplay between the people involved, both in the denizen country and in the volunteers, the expertise in both populations, and the resources from both populations. That includes an understanding of what's capable in your host country or in your host community, and what you're actually able to bring along with you, and the time commitments and the time requirements. Next. Everything can be boiled down to a mathematical formula in my head. So I created this formula for capacity building where C in the formula equals capacity. And in my early history in going to Ecuador 25 years ago, I thought that I would just pick a community that needed help. I picked, for example, Guayaquil or Loja or Cuenca, and I would go down there and say, well, I'm a hand surgeon primarily, so I'm going to go do syndactyles and polydactyles. And although there was a plethora of patients that could do it, I never really asked them in my early years, well, what do you need to have fixed, right? And every population with a high penetrance of birth defects also had other birth defects, and it was years before I brought plastic surgeons with me to fix the greater number of cleft lips and palates that were there. So my early failures were I didn't identify what the local needs were so that I could enable them to fix what they were identifying as a problem. So enabling is one of the first steps in capacity building. But it means nothing if you don't sustain that capability. So enabling and sustainability are the fundamental building blocks of capacity building, with one other recognition, and that is the X. And X are the potential complications, and you have to plan for your complications. We all do in wherever country we practice, in our elective and trauma situations. When you're visiting a country, the chances are that every perceivable complication that could happen will happen, and ones that you were not anticipating will happen. And the reason why there's an asterisk next to it is because it's meant to imply, let's just replace that with any number. Let's pick it with the lowest number squared. The impact and the ability to distract from your capacity building with a complication is overwhelmingly significant. It's much more amplified in a fragile environment than in an environment that is resource rich, where most of us practice our day to day. So enabling and sustainability, which occupied the second phase of my global volunteering over the last 30 years, was nice, but then, and I always thought I did a good job avoiding complications, but preparing for them was another issue, and that's really what I focus on now. Next slide, please. When we talk about people, the most important things that I've learned over the years is, number one, regardless of what your role is, a volunteer, whether you're a lay person or the coordinator of the program or a translator or the son of a surgeon who's coming to get experience, like the very center guy in that photograph, you have to be a leader, regardless of what your role is. Every single team member has to function as a leader. Two other points are that you have to be a teacher, and most importantly, you have to be a student. Every person who you come in contact with in a Denison country, in a host, can be your teacher. And I have never returned from a trip and not learned something from one of my hosts that I have not implemented in my private practice. How I close fasciectomies is something that I learned years ago and is limited by skin grafting tremendously. And learning and the attitude of learning projects respect that is an immeasurable return when you develop relationships. Conflict resolution is important. First of all, if you adopt an attitude that you're a leader, it's something that you're going to work on. But there's 5 major pearls that I think are necessary to avoid conflicts. One is don't criticize anybody for any reason. Your life experiences are different, but theirs are, whether they're your co-volunteers or whether they're your host assistants or your local champions. Criticism is that's not constructive or not private with the intent to construct is very damaging, particularly if it's overheard. The You may see things that are out of your norm, and you have to deal with those in a very mature, very positive way. Many of the places that I go to have very poor resources. The last trip that I went on, someone was criticizing one of the scrub techs because we were sterilizing something that was needed in Sidex, something that's not acceptable in the United States, but that's their only resource. They were criticizing reusing Bovie tips and Bovie wires and NG tubes and LMAs, but that's necessary. And the criticism shouldn't have been projected because it offended our local host. The third pearl, submerge yourself into the local environment, not just your hosts, but your patients and their families as well. The reward from that will be tremendous. The respect that's projected from that will be palpable. Lastly, don't project your standards onto them. If they're asking for teaching, do so. They read, they're smart, they know what the standards of care are in the United States and in other developed countries. If they don't adopt them, it's because they don't have the resources to do so. And then lastly, if you need to step out of your comfort zone, don't experiment. Don't do something on a patient that you would never do in this country, because that's going to be perceived by your host. It's going to invite a complication. You need to step out of your comfort zone, grab a mop, clean the floor in the operating room. Next slide, please. That will be very appreciated. I think I've touched on most of these things. With expertise, again, be a teacher, support and elevate the talent of your collaborators, define goals together. And often when your trips are mature and you have developed relationships with local champions, whether they're physician champions or whether they're local lay people that you really, really make the trip successful, develop goals together, listen to them. What their needs are has to be addressed. It's not what you think that they need. They'll tell you what they need and build capacity around that. Provide education, whatever you can do. I have bought internet service for several places I've gone to. They have to communicate with you afterwards. Enable that. Share your expertise after you leave your mission trip. There will be complications. They're going to be the ones who follow up with your patients. Your expertise doesn't stop getting shared just because you've gotten on the plane, and you have to enable that communication so that it's an ongoing process. Next, please. Resources. The best way to adjust your resources, in my experience, is to plan for your complications. There will be wound complications. You have to procure extra supplies to leave them behind because they will be consumed. There will be infections. I always leave Rocephin as a parental antibiotic behind, and vancomycin. I take extra with me. They don't have the capacity in most places I go to give Ancef 3 times after surgery. So I give Rocephin on a weight adjusted dose before the surgery as my prophylaxis, and it covers me for 24 hours. And I leave extra Rocephin behind, and augmentin solution and pills behind, because there will be infections, and I don't want to be responsible. I need to be responsible because the patient likely cannot afford or even have access to augmentin pills or Rocephin injections. And certainly the hospital may not have access to it. And so enabling that hospital system or your local champion physician or surgeon to cover the complication that has your name on it is critical. You have to provide, again, contact information, and you have to be sensitive to the needs of the hospital administration as well. Free healthcare isn't free. It's a point that will come up through this the series of talks today. It costs about $100 a patient to manage them surgically at the most recent hospital that I go to in Honduras. And so I pay them $100 for every patient that I operate on. That not only ensures that I'm not tapping into the limited resources in a community that already has limited resources and an inability to repair those. I'm compensating for it from the beginning. X-rays cost money. The X-ray tech costs money. The scrub nurses that work with us cost money. They may do 2 or 3 cases and 1 shift per operating room per day, but we're going there filling 10 operating rooms. And we need extra techs. We need more people in the supply rooms, and we consume more supplies. So we have to pay for that. It doesn't make sense to leave a hospital system poor because we've come down there and done a bunch of surgeries. Next slide, please. Lastly, on my part, plan on repeated visits. I've gone to many places where a stage 1 or 2 palate reconstruction was never followed up with a stage 3 palate reconstruction, and every time the baby drank milk poured out of their nose. So you have to plan for stage procedures. You have to plan to go back to the same location, or make sure that they can get to where you're going to be the next time. Follow up is critical. Patient identifier so that you can follow up is critical. Every patient I operate on gets my cell phone number. I make sure that we have the ability to communicate before I leave the country. And that type of ability to communicate with them creates the ethical background that's necessary for you to deal with a complication, and to ensure that the next time that you visit, that they know that you're coming, and they know when and how to be there. The other part that's important with the communication is, if you go to a particular location only once a year, staying in direct, intimate communication on a very regular basis with your local champions is critical. Not only so that you can digitally triage patients and make your stay there much more effective, but you want the lay people that are involved with getting the local politics matured and set for you. They need lots of time to prepare for your arrival. And so intimate communications, not just 2 months before, is very critical to keep an ongoing program running smoothly. Kathy?
Am I
Yeah,
on?
next slide.
Yes. Okay, perfect. So We're going to do a bit of summary based on the conversations that I've had as a mentee with Dr. Perlmutter about the outreach medical collaborations. There's multiple components to these collaborations. First is the medical outreach component, where you have a medical service, a surgical service that you provide to a community. There's a component of funding and resources that goes both ways, both available in the local community, and also you may want to bring as a collaborator with you. There is a component of education that goes both ways, both for the team that is traveling or providing that care, and also those who are from the community. There's always an exchange of knowledge, even if it's not built in a form of a didactic and a classroom setting. If it's possible to do that in an actual teaching program, fantastic. But even without that, there's always a knowledge exchange that happens through these efforts, and that's very important. So, in terms of consultations and follow-up, that's an important component of these collaborations as well. As Dr. Perlmutter alluded to that, complications arise, and the procedures sometimes need to be multi-stage. So they have to be plans in place for follow-ups and checking in on your collaborators as time goes on. And there's a time commitment that needs to be in place and clearly communicated between the parties. The times of global surgery are changing very fast. There is movements towards different models as we're becoming more and more aware of equity issues and ethical issues that can be part of these collaborations. And some component that is very important to keep in mind is the bilateral equitable nature of these collaborations. And that has to be considering not only our colleagues that are going to be involved in this collaboration with us, the medical care providers, the staff of the hospital, the administration of the hospital, but also the community members that are involved in these efforts oftentimes. And that is something to keep in mind, that it should be beneficial to everyone and not unidirectional, not through a one-way sort of a collaboration. Most of these collaborations have short-term or long-term goals. In short-term, we see that they fill a gap. Perhaps it is a disaster or a humanitarian crisis that we're supporting, and that's going to be a temporary gap that needs to be filled. Or there is long-term planning in the collaboration where we're going to build capacity over time. But the ultimate goal of all of these, whether it's short-term or long-term, should be to put yourself out of business and enable the community to get back on their feet and be able to carry out the services the best way that they know how and what suits their environment. To begin with, all these collaborations starts with finding a collaborator, and that involves finding a colleague in the region and finding and identifying local champions that you can empower to be part of this collaboration. It is important to consider the needs, but also resources. And this is where we often see needs assessments come in to play. And sometimes we also see asset mapping come in. And it's very important to look at both, because sometimes you will find resources within the communities that are actually able to be sort of reused or repositioned to fill gaps that exist. So it's very important to keep both in mind. It's important to ask our collaborators or potential collaborators what their views and interests are in terms of collaboration, to have this conversation, not to assume that it's obvious to everybody so we're all on the same page, and to go into these conversations with humility and not with a sense that we know how to do everything really well and that's why we're coming in to fix a problem. This is where you will have a bilateral exchange, and you will be able to discuss what will the bilateral exchange look like for both parties to sort of change the dynamics of conversations and bring everyone on the same playing field. And it's important to remember that local champions know their environment very well, and they have a deep understanding of what needs to be done and how, and to hear them out and to listen to their views is very important towards the success of these collaborations. Next step in setting up these collaborations is to find a suitable environment. And this is something that must be done with our collaborators. We can identify a hospital or an environment with a potential capacity building resources that we need. It's important to, again, gauge the interests of the community, engage the interests of the, the administrators and people who are involved in that environment as well. Look at what is the personnel that is available, what needs to be brought in, and in terms of infrastructure, what is available, running water, electricity, the basics, and, at a higher level, imaging, pharmaceuticals, and so on. And we need to remember that solutions must fit the environment. What works for us at home may not work everywhere. And some of the solutions that they have environment, and we may actually learn from them and bring them back. To me, the prime example of this is the COVID-19 pandemic, where in the United States and most high-income countries, we were really paralyzed by the lack of PPE, whereas in other countries, in low resource settings, they were much more adapt to looking at low resources and high volumes of patients and being able to manage them. Something as simply as tossing a PPE into the trash can every day, every time we enter and exit a patient room, for us was out of the realm of thinking. And for them, it was very common to look at how do you stretch our resources to adapt to larger volumes of patients. And that is something that we need to also be keeping an open eye for and learn from. The other factor is ethics and culture. Cultural competency is not one size fits all, and we need to have an open mind and interact with our collaborators as much as possible with cultural awareness and humility, but also build a relationship that we can rely on them to teach us about their culture and be our bridge to their community and teach us how to interact with patients and their community in ways that are respectful, supportive, ethical, and acceptable in their culture. In terms of commitment, there is a long-term commitment often in capacity building missions and medical outreach collaborations, and that is multifaceted. We make a long-term commitment to collaborators, to the patients, and also to the trainees that are involved, both on the ground and those who accompany these efforts. Complications, as it was discussed by Dr. Perlmutter as well, are going to arise, and they are, again, multifaceted. They could be medical, surgical complications. They could be collaborative complications in form of changes in the political landscape, administration, conflicts that arise within the team, or they could be complications that are based on ethical issues. And in each case, we must keep an open mind and be ready to sit for a conflict resolution and complication resolution and overcome the challenge together with our collaborators for the best outcome for everyone involved. And as Dr. Perlmutter mentioned before, it's important to remember free healthcare is not free, and be mindful of what is our burden on the community as we enter these environments and participate in these collaborations. Conflict resolution depends on our team dynamics. It's important to create the dynamic that everyone feels comfortable to raise concern and voice their issues, and be able to have regular check-in with our collaborator, even if we are not on the ground in an active collaboration, taking care of patients, but over time, as Dr. Perlmutter mentioned, keeping a communication with them, checking in, seeing if there is any changes, sort of a pulse check on the collaboration over time, and come up with collaborative solutions. If there is a conflict, then we must come together to resolve it as well. And finally, and this is a nod to our next speaker, Dr. Schreim's book, Solving for Why, it's important to remember your why. Why do we do this? What do we gain from these processes? And this picture to me is something that I always remember when Dr. Perlmutter posted this. I remember on Twitter, it was very interesting to me because what you see, the young doctor that you see next to Dr. Perlmutter is Dr. Alba Silva. Dr. Perlmutter operated on Dr. Silva when she was 5 years old and separated 8 of her fingers that were fused together. Later on, Alba went on to become a physician, and she joined Dr. Perlmutter on a medical outreach program in Honduras. And this must have been just an amazing, amazing feeling for Dr. Perlmutter. And what a beautiful way to see the work propagate that way. Thank you. And with that, I would like to pass on the mic to Dr. Schreim.
Thank you, Kathy. Thank you for both of you, Mark and Kathy, for that great presentation. Thanks for the plug of the book. I appreciate that. Let me, if we could get thank you for getting my slides on screen. Let me start. So as Kathy said, my name is Mark. I am the International Chief Medical Officer for an organization called Mercy Ships. I'm also a lecturer in the Department of Global Health and Social Medicine, specifically in the program in Global Surgery and Social Change at the Harvard Medical School. And I want to talk about a slightly different approach to the global surgery crisis, the global surgery problem that we all face. And that's through this organization that I work with called Mercy Ships. These are my disclosures. I get consulting fees from Global Surgery Advisors, speaking fees from Brightsight. This is not a paid talk, as well as some royalties on the book that Kathy mentioned from 12. These have nothing to do with what I'm speaking about today. So in the about 10, 12 minutes that I want to speak before we turn it over to you all for questions, two things I want to cover. First, just who is Mercy Ships? Real brief introduction to who we are as an organization, and then I will spend most of the bulk of this talk on how do we work, how do we address a lot of the stuff that Mark and Kathy were talking about. So let's start with the who is Mercy Ships question. Fundamentally, we are a charity. We are a non-governmental organization that addresses the issues of global surgical access primarily from the decks of hospital ships. We have 2 hospital ships. You can see them both here. As an organization, we've been around since 1978, so 46 years. I've personally been working with Mercy Ships since 2008, so 16 years. 2 hospital ships. The one in the background on the right of your screen is the Africa Mercy. She's our older ship. She's going on 50 years old now. And the one in the foreground to the left is our newer ship. It's the Global Mercy. She has been in service for only a few years. The Africa Mercy, the smaller one, is a 500-foot-long converted Danish rail ferry. She's 8 decks tall. The hospital is on the 3rd deck. There are 59 patient beds and 5 operating rooms on that hospital ship. On the Global Mercy, about the same length, 550-ish feet long, but 12 decks tall. The hospital takes up 2 decks of the ship, 102 patient beds, 6 operating rooms on that hospital. And on each of the hospitals, we also have obviously recovery rooms. We have ICUs. We have radiology with CAT scanners, x-rays, etc., pathology, pharmacy, rehab, speech pathology. Basically, the goal is to have just about everything that you would need to deliver surgical care here in the US, where I am, but just packaged onto a ship and docked off the coast of sub-Saharan African countries for about a year at a time. We've been focusing exclusively in sub-Saharan Africa since the early 90s, since 1992. And we will be focusing on the continent for the foreseeable future. Each ship spends approximately 10 months out of the year in the country, and then 2 months getting repairs, refit, et cetera, and then goes on to the next country. Occasionally, we will spend a couple of years in the country with our ships, and that's where we are right now. So our smaller ship, the Africa Mercy, just arrived to Madagascar 12 days ago, and will be in Madagascar for 2 years. The bigger ship is in Sierra Leone, has been in Sierra Leone for about 6 months, and will continue for another 18 or so months in Sierra Leone. Now, when I say that we are in the country for 1 to 2 years, that's just the time that the ship is there. We actually engage with countries for significantly longer. We engage with countries for 5, 6, 7, potentially longer than that, 5, 6, 7 years, potentially longer than that. And that is for many of the reasons that Mark and Kathy brought up earlier, which is the long-term follow-up, the long-term education, the long-term capacity building in a country does not happen in 10 months as you sail a ship in. But I'll talk more about that in the second part of the talk, which is how do we work? To address this, let me put up here on the screen a quote that I absolutely adore. It's a quote I turn to often from Desmond Tutu. He said, "There comes a point where we need to stop just pulling people out of the river. We need to go upstream and find out why they're falling in." And in that quote, if you've worked in global health, global surgery, development, anything like that for any length of time, you'll sense in Tutu's quote a tension in our field. It's a tension between relief and development. Relief is acknowledging that there is a massive unmet surgical disease burden right now. You know the numbers, 70% of the world's population cannot access surgery when they need to. An additional 143 million more operations need to be done every year. 2.5 million more surgical providers need to be trained. So Relief is acknowledging that there is an unmet disease burden right now and is saying we've got to meet that disease burden. These are patients that need care. Development starts from the same place. It recognizes that there is a very large unmet disease burden right now, but then it says, gosh, if we don't figure out why that disease burden is there, and if we don't address the things that lead to that unmet disease burden, then the line of patients coming to our door will never stop. Kathy's slide about working yourself out of a job, we'll never be able to do that if we don't understand what's happening upstream of that patient that's in front of us. And unfortunately, often in the development conversation, the global health conversation, those two sides are put at odds with each other. They're put as often in conflict with each other. You've got the sort of deeply held relief people who say correctly, if we don't deal with this surgical issue now, these patients will, to not too fine a point on it, they will die. 16.9 million surgical deaths every year. Okay, that's true. But then the development folks will say, yeah, but if you do that and you deal with, you just do the relief, then you'll never, again, stop the line, and you will probably build up dependency and all that sort of stuff. So people got to fight about this in academic conversations and development conversations. What I love about the approach that Mercy Ships takes is that we focus on the word just in Tutu's quote. We need to stop just pulling people out of the river. So we do both. We focus on pulling people out of the river and also going upstream and figuring out why they're falling in the first place. So we have two programmatic pillars: our direct service delivery, our direct medical services, and our pillar of education, training, and advocacy. And let me tell you a little bit about each of these pillars before I open it up for questions. So we have 5 goals in our direct medical services, the pulling people out of the river. Fundamentally, our goal is to treat the current surgical disease burden in the countries that we partner with, and to do that in 5 ways. Fundamentally, the very beginning, we are a surgical organization, and so the first line here is restoring the health of surgical patients and decreasing their disability due to their disease. So we measure those things. We measure disability adjusted life years. We measure surgical complication rates. So we do what any hospital that provides surgery would do. But then we also recognize that when we sail a ship into a country, because of the size of these ships, they're not cruise ships, but they're also not small, we have to dock in the large port cities, and often those are the capitals of the countries, which are the richest parts of these countries. So we make a concerted effort to get patients to the ship from the rest of the country. At least 50% of our patients in any one country come from upcountry, come from away from those big port cities and their environments and their environs. So we aim to reach the hardest to reach patients. We also aim to address the fact that getting surgery places a financial burden on patients and families. Not only do we offer the surgery for free and all the care around it, but we offer transportation. We do our best to decrease the risk of catastrophic expense that patients coming to us face. But then we also recognize that doing all that, sailing a big white ship in offering surgery for free, can have deleterious effects on the market for local surgeons. We have been working on studying the magnitude of that effect and understanding how to get around that effect. So working so that we do not actually undermine the work of local surgeons after we sail the ship back away and after we stop engaging with a country 5, 6, 7 years later. We are fundamentally a faith-based charity, and that's reflected in the last line here. Many of the conditions that we treat, which I'll show you on the next page, like this patient here with the facial tumor, bowed legs, clefts, etc., to some degree rob from patients their seat at the table of humanity. People no longer look these patients in the eye. They're distracted by the tumor itself. The patient becomes something less than a full-fledged human. And so we work to restore to patients and their families their God-given right to a seat at the table of humanity. We do this with 7 surgical specialties. We do head and neck and maxillofacial surgery, the tumor that you saw on the last slide. Reconstructive plastic surgery, this is clefts, but it's also burn contractures, syndactyly, and similar procedures. General surgery, including goiters, specialized pediatric general surgery, pediatric orthopedic surgery, primarily the bowed legs and the club feet, ophthalmic surgery, primarily cataracts, and women's health surgery, which is primarily obstetric fistula. We also have a very large dental program, and we have a palliative care team also. Occasionally, because access to care is so poor in many of these countries, especially tumors will come to us that are unresectable. They are into the cranial vault, etc. And so we don't just send those patients away and say, sorry, good luck. We have a palliative care team that follows up with them while we're there. That's our direct medical services. Our education, training, and advocacy is the second half of the Desmond Tutu quote. It aims to decrease future surgical disease burden in the countries that we partner with. Now, the late Paul Farmer used to say that for access to be present in a country, you needed four things. You needed the staff, the stuff, the space, and the systems. The people to provide the care, the equipment to provide it with, the places to provide it in, like ORs, and the systems to support them. No one NGO, no one mission is going to be expert in all of these. For the last 12 years, we have been focusing on the staff side of that equation, and that is where we go. Now, we do have equipment donations and infrastructure development, but we tie that into our staff development. And we approach staff development with the recognition that the primary issue that surgical patients face is not that the surgeons in the country aren't adequately trained. Sure, that exists, for sure, that's true in every country, but it's that there aren't enough of them. There simply aren't enough surgeons, anesthesiologists, and nurses working for surgical patients. So our primary goal is to increase the number of surgical providers available to patients. And when we say surgical providers, we don't just mean surgeons, anesthesiologists, and nurses. We mean the entire system, the entire ecosystem necessary for a surgeon, anesthesiologist, or nurse to do their work. Biomed tech, sterilization, pharmacy, laboratory, dietitians, hospital management, hospital pharmacy, hospital chaplaincy, etc. In fact, probably the bulk of our education and training work is not at the surgeon anesthesiologist level. It is at that ecosystem level. Dovetailing with what Mark and Kathy said, we aim to co-create these with the countries that we work in. So we do that. We ask the countries what they need to create long-term, sustainable, and potentially accredited educational programs to address their felt needs. Again, we don't come in and say, we do radiology, you need radiology. We ask, we work in staff, which part of your surgical system can we help in? We work to reach the hardest to reach providers, like we do with patients. And then we're just growing an advocacy arm to advocate for surgery's place in healthcare at national and international forums. I'm getting texts that I'm out of time, so I will end here with, again, this Desmond Tutu quote and turn it back over to you all.
For that wonderful presentation. Now we're going to actually have a bit of a discussion with both of you. I want to start with a question that I think it's something to address head on, because we hear about it a lot over the recent years in global surgery. You know, over the past few years, the medical outreach collaborations or missions have been under a lot of scrutiny for their negative intended or unintended impacts that they may carry. And you have both shared quite a bit of experience and extensive work in this arena, and success actually in capacity building through missions. So if for audience members, if they want to join in and if they want to enter this type of activity in global surgery, what are some of the factors that you recommend they consider so that they can avoid harmful practices?
Well, first and foremost, I think I'm off mute. Yeah. First and foremost, tie in with a group that is experienced. I mean, we represent just 2 of hundreds of groups that participate in global surgery. But the strongest point would be to join a group that focuses on identifying local champions, because that's the biggest mark of maturity. Instead of being the local champion, identify the local champion, enable them, and sustain them. That creates an environment of sustainability, and to walk into a group that has that practice ethos and participate with them uh, is the best way to learn, because you're learning from decades of people who've made mistakes. Um, and, and we all love to point out our early mistakes from 25 and 30 years ago, um, because the local champions back then were the ones to identify them for us. And we had to humbly accept them. Um, uh, Partner with a group that's established and has their act together. That's the number one thing I could advise. If they're sustainable, it's because they're doing it right over the years. If they're not sustainable, such as the World Surgical Foundation, International College of Surgeons, and Mercy Ships, et cetera, Smile Train, et cetera, there's hundreds. But you have to pick one that's proven their purpose.
Yeah, listen, I completely agree. I'll add to that. Think about the model also of the outreach itself. Um, if we think about how we've all been trained as surgeons, we were not trained in short courses, 9-day courses on, I don't know, pediatric anesthesia or whatever. We were trained in residency programs and which are basically apprenticeships. And so as you want to get involved with an organization, if you want to get involved with an organization that is doing this, it is the sort of short mission trip without the sustained follow-up that Mark and Kathy were talking about, that benefits us way more than the patients or the providers that are there. And so, I guess flip that script and think about whether you would want to be either a patient or a provider receiving that group, and ask, okay, are there things about this group that, yes, I would want to receive, or conversely, there are things about this group that I would not want to receive? Because look, we all recognize it. There are, as Kathy said, there are issues with short-term mission trips. They've been published, they're out there. And so we need to not double down on it just because it's good for us.
Yeah, our ethos is to do no harm, correct, in our local practices.
Yeah.
The best way to do harm, besides the direct injury to a patient, is to rob that local environment of their local resources, which they will depend on once we leave. Um, and, uh, and that's a crime. So we actually do harm by not sustaining.
Thank you for that. So we've talked about complications, in both presentations. Uh, can you share an experience of a complication that you had not planned for, you did not think about going into a new environment, and how you navigated that? Because I think that's something that might be a prohibiting factor for some, the concern for that.
I can go first. The complications happen at multiple levels. I put my hand on a family member's knee as I was trying to assure them that their son would do well with surgery, and I offended her immensely. Um, I did not have my ear to the ground on the local culture. Another time, I got the Spanish word for neck and another body part mixed up, and I asked a very prominent politician. So I thought I was asking her to move her neck over on the table as I tried to assist her, um, and I offended her immeasurably by trying to practice my Spanish. Um, uh, and the worst extreme, so they range from direct personal insults at the late, in a common person's level to a highly charged political level. Sorry, this is silliness. But the worst that's happened to me personally is the death of a patient, right? Um, Succinylcholine was given before an airway was established, and the child, against all clear advice, to not eat or drink. Uh, I mean, I'm a hand surgeon, but I did my first tracheostomy sucking rice and beans out of a 5-year-old trachea. And then the sequela afterwards about the family not having enough money to take their child back home for burial. And it was a 5-day donkey ride in. And of course, you can't put a body on a donkey for 5 days. And the whole environment of trying to deal with something that was so emotionally charged is important. So you have to be prepared for the ugliest of complications, and that means sometimes you have to open your wallet, right? Um, and so that took financial resources. The other examples took humbling resources that I had to pull from inside, um, and it runs the gamut in between that. The first time I realized that I should have left antibiotics back was because I didn't, and 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 the damage that the infection. I was the surgeon. The infection has my name on it, but I didn't prepare the local surgeon. I was able to wire money, but a 36-hour delay with an infection is a huge ethical problem. So, that's why in the beginning of my talk, the first thing I said was plan for your complications, because those are the things that are going to drag you down afterwards. You're going there because you're an ethical person. Prepare for things that will compromise your ethics, um, and that's the best approach.
It's interesting that we're both going to draw on the death of a patient. These are the complications that sit with us as surgeons for the rest of our lives. Like I will never forget this one patient that I'm talking about. It was a venous air embolism, so I agree again, unsurprisingly, with everything that Mark said. In this particular case, you never prepare for. There's no way to prepare for those sort of out of left field complications. You do have to have your system prepared to deal with those out of left field complications. In this particular patient's case, similarly, was from far away from where the ship was. I benefit from working in a fairly established system on the ship. So we have connections with other NGOs, we have connections with the Ministry of Health, and basically in this particular patient's case, there's nothing you can do to soften the blow of a mother losing their child. Full stop. Nothing you can do. However, there is something you can do about treating that family with love, with care, and with respect, even afterwards. In this particular case, it looked like our ship carpenters like staying up all night building a coffin for her. It looked like us partnering with another NGO to get a helicopter and not have her, go down the 5-day donkey ride to the other side of the country. The other thing that I'll say, these are hospitals. Hospitals have complications, and systems for complications exist in hospitals in high-income countries. We have morbidity and mortality rounds in our hospitals that we work in at home. We should have morbidity and mortality rounds in the work that we do. So we have one. We've established an M&M. We call it a hospital review board, but it's essentially an M&M. The last thing I'll say about this, though, and it's something that I learned from working on mercy ships and I've never seen done before. So there's, as I was saying, there's a lot about treating the patient, the family with love and respect, but there's also a lot about treating the providers with the same thing. This was an ad hoc thing that we've now kind of more formally established, but it was an ad hoc thing. The day before the formal M&M, where we talked through all the systems and figured out and some things did change, what we could change to decrease the chances of that happening again. Our hospital director at the time called, basically, he didn't give it this name, but basically an emotional M&M. He gathered all the people that were in that room, that were around this patient, that took care of this patient, for simply an emotional debrief, and just like talk about what you're feeling, because we are so used to in medicine driving forward. You know what? The ICU, a patient dies in the ICU bed. We clean the ICU bed because there's somebody else coming into it. And we saw in the pandemic how much that approach destroys physicians and nurses and providers. And what he did in calling that sort of emotional M&M really kind of transformed the way we all approached the death of this patient.
I really appreciate that. I can share that in the time that I was with Incision, or the last conference we had, it was actually the most requested session to have a conversation about how to take care of yourself and your colleagues emotionally as you go through global surgery work, because it can be very taxing. So thank you for sharing that, both of you. I am not going to do a wrap up of this session because I think we have a very unique opportunity. I'm going to ask you the hardest question actually yet. I'm going to give you each 1 minute, and I would love to hear from both of you, who are role models to many of us, myself included. What is it that you are most proud of in your career in global surgery when you look back? I know it's very hard to wrap that up in 1 minute, but I would really appreciate it if you both could share with us. And I'm going to start with you, Dr. Schreim, this time.
Wait, that's not fair.
I told you it would be the hardest question yet.
It is a hard question. You know what? I don't know if this. It's always hard when somebody says, "What's your favorite patient?" or "What's your favorite country?" or like I don't have ready answers to these, so I don't know if I'm going to pick one. But simply, honestly, it sounds cheesy, but I really mean it. It is a privilege to have been at the right place at the right time. My career in global surgery got started when I first started working on Mercy ships, and then really kind of kicked off with the Lancet Commission. And a lot of that was just sort of being a PhD student in Boston when the Lancet Commission was happening. Being able to have been a part of this conversation, to document and study the magnitude of this crisis, and be able to be a tiny part of moving the needle in that. That's my favorite.
Dr. Perlmutter?
I think I can add the conclusion, and then I'll give the reasoning first. The conclusion is that any person, no matter about their station, can make a difference. Right. I, like my colleague, do not have as many letters after my name. I'm not a professor any place. I'm a country hand surgeon, but I've done 40 overseas mission trips, right? I've operated on thousands of kids and hundreds of adults. The difference, I think the thing that I'm proudest the most is that I've recruited many hundreds of people to follow me because I don't have a trail of residents, 5 surgical residents following me every year that I'm encouraging to follow, that come along with an implicit or else, and that the productivity is measurable because we're helping people that would otherwise never have access to care. And when the ultimate goal is to train somebody that you say goodbye to on the way to the airport, to carry over what you've tried to teach them, and then you walk back with knowledge that they've taught you, it's not so much the patients that I've operated on, it's the dozens of surgeons that I've enabled afterwards. Like Alba in Ecuador, right? Her promise to me when she was 5 years old was to become a surgeon. So, and there's people who are surgeons when I met them that are better off because we've worked together, as I am. The collaboration is everything, in a word.
Thank you so much for that. You both have and continue to inspire all of us who are trying to be in this field and continuing to be part of this. And I hope that our audience was also inspired from hearing the work that you do, and they will join you in global surgery. Thank you so much. And with that, I'll turn it back to Mr. Rebel.